the most frequency is the GCT, means giant cell tumor, and the chondroblastoma was very often in this condition. And in the metaphysical, we can already see the osteomyelitis and the osteo and the chondrosarcoma. In the diaphysis, which was round cell lesion, so it's happened, and it could be ABC, it could be a chondroma. And this picture shows the characteristic locations of simple bone cyst. This was a simple bone cyst here, and in the proximal humerus. And this picture shows chondroblastoma in the epiphyseal. The epiphyseal is one here, that's one here. And the giant cell tumor, the GCT, is very important in the epiphysis. The tubular picture shows here, we have characteristic locations was adiomatula. And we have chondroma in the sacrum, in the cervix. It is a chondroma, this picture shows in the pelvic. And the osteoblastoma, we have the spine, the posterior position X-ray shows the osteoblastoma here. And we should focus on the density of the lesion. First, it can sclerotic cortical lesions and can lytic lesions in children. And we have lytic lesions in adults, and the plastic lesions in children, the plastic lesions in adults. First, we see the sclerotic cortical lesions. This kind of lesions happens always in the round bone, and this was osteoid osteoma. And this is not a tumor, this was a broadized abscess that was very similar to the tumor X-ray. And this was a broadized abscess. And in the lytic lesions in children, we show this cranial picture. This was lytic lesions. Okay, this was a child, and he has asaphenia felix, granule. And we have leukemia, also in the children. A lot of lytic lesions. And here, a lot of the lytic lesions in children. And lytic lesions, if that happens in adults, we first consider was metastatic lesions. And it can be from the lung cancer, the renal cancer, or the thyroid things. This picture shows metastatic thyroid carcinoma. Here we got lytic lesions in adults, and here, and it was very often. And this was another picture shows a lytic lesion in adults. That was medical myeloma, a lot of lytic lesions. And this shows another lytic lesions in adults. This patient have primary bone tumor. This was a chondrosarcoma. We have another kind of lesions. For example, the plastic lesions. It can happen in children. Yes, lymphoma causes the plastic lesions in the spine. And this picture was prostate carcinoma. Shows the plastic lesion in adult, and in the pelvic you see this highlight here is highlights here and here, and that was prostate carcinoma. And this picture shows another plastic lesion in adults. And this plastic lesion here is also a lymphoma. And this picture shows Paget's disease. It can be a blastic lesion in adults. Here, these pictures is, and we have pathological fractures. Also, it indicates a tumor happens. And this was a really good picture of the in their tibial part. And we should know the further diagnosis. We not only need plain X-ray, we need computer tomography. It is most helpful in assessing ossification and calcification and in evaluating the integrity of the cortex. The best imaging study should consider to localize the nodules of the osteocyte, osteoma, and to detect a thin renal reactive bone around an aneurysmal bone cyst, and to evaluate the calcification in a suspected carcinogenous lesion, and to evaluate interstitial cortical erosion in a suspected chondrosarcoma. So we know the CT of the land also is the most effective study to detect pulmonary metastasis. This is a CT, and this is a CT of the pelvic, shows a lot of breakings, and here maybe, and here it were lytic lesions of this patient. And we can also do MRI. MRI is the most accurate technique for determining the limits of the disease, both within and without bone. And if we do MRI with a specific diagnosis with tumors such as leucoma and hemoglonia and the hematoma, or the pigmented variolinoidal adenoids, all of these have very characteristic appearances. With regard to most neoplasms, however, the MRI appearance is non-specific. However, in the soft tissue neoplasm deep to the facial of the larger than 5 centimeters, greatest definition showed the considered highly likely to be a sarcoma. This is MRI, and this MRI shows the tumor is right here in the spine, and is the compressed to the spinal cord. This patient may have symptoms of his lower extremities. And this shows another way, it's DSA, and this shows the tumor breast spine. And we can also do the ECT and the PET-CT, and this kind of bone scans can indicate to detect the skeletal metastasis and to determine the presence of medical lesions in such entities, and the osteochondroma, the inchondroma, the fibrodysplasia, and the histiocytosis. The bone scan and frequently false negative in medical myeloma should be cautioned, and with the expansion of myeloma, however, virtually all malignant neoplasms of bone determination increased uptake on technique bone scans. However, most benign lesions of bone also demonstrate increased uptake. This is an ECT, and this shows we got a lot of metatarsal bone tumors here and here, here in these positions. And that also shows the dark bone. And the biochemical test also can help you to diagnose a bone tumor. For example, the Röntgen's protein that always shows the medical myeloma, and the alkene phosphatase. It reflects the osteoblast activity, and the acid phosphatase, and it shows the prostate cancer or metastasis. we have pathological examinations. We have golden standard for the bone tumor, and we want to confirm this tumor, which is doing the pathological examination. And it can be done by the open biopsy. You can shoot a cat and resection. We have to do the needle biopsy to use for osteolytic lesions of the spine and the extremities. We have precautions for open biopsy. If you want to do open biopsy, you should follow these things. First, the surgical approach. If we do an open biopsy, we first consider is the surgical approach. We try to avoid important blood vessel and nerves, and in the approach, you need to take into account the next surgical approach and the resection surgical approach. That is very important. And be in line with the principles of the tumor-free surgery. You do not touch the tumor if that was very necessary. And you should know the cut range of the surgery. This picture shows the cut range of the open biopsy. We should be considered containing with the tumor cell and the tumor capsule, and the reactive zone of the tumor is like a watermelon. You see, we going to catch this position, and it should be this black one was tumor cells, like, and the tumor capsule here, and the negative zone of the tumor. Okay. And if we are doing a surgery, we should consider the surgical staging of this bone tumor. That means the GTM systems to classification the staging of this kind of tumor. We have the surgical classification, means grade G, and the surgical area, territorial T, and the original or the distant metastasis, that means metastasis is short for M. And these clinical surgical classification, grade G, we can do the clinical manifestations and the immunology, the characteristics, and the morphologies. The territorial, we can consider the territorial as a component of referred to the natural barrier of the host for the growth of the tumor. And in this system, we should know the things that G0, M0, that means it's a benign tumor. If the G1, M0 is borderline, and if we got a tumor which grade classified to G2, that means this tumor is a malignant one, and the M1 is a metastatic one. And we also have other classification systems, for example, the Ankins system for staging benign and malignant musculoskeletal tumor. And we could divide this to benign tumor to the malignant one. And benign tumor could be a latent one, and to active one or aggressive one. And if tumor is a malignant, we can divide to the stage 1, 2, 3, and it could be 1A and 1B, and the 2 could be divided into the A and B. So we got different ways to staging these kind of tumors. The differential diagnosis of benign and malignant tumor, and this table is quite an important one. First, let's look into the benign tumors have features like here, and the malignant have features like here. We can differentiate these two kind of tumors from the symptoms, the signs, the X-ray findings, and the cell morphology, and the biochemical tests, and the prognosis. First, we see the symptoms. As benign tumors, first we can see a mass occurred, and the mass may be a slow growth, which in the malignant one we can see is a rapid growth. It's a rapid growth, and in the benign one was slight part, slight pain, or have no pain, and in the malignant one we always have a heavy pain, and always that was happened in the night. And in the benign one, there's no systematic symptoms, and in the malignant one, can be patient have fever, have edema, or the advanced other things. And we have different signs for the benign and the malignant one. It can be in the benign tumor, it can be clear boundaries. Which in the malignant one, it can happen answer, and the surrounding tissues may adhesive and not so clear means. And in the benign one, there were no surface changes and no tenderness, or a little bit means mild tenderness. And in the malignant one, we see it could be high fevers, and it could be tenderness. So that was quite different, and there are also difference in the X-ray findings. In the benign one, words always can be expansive growth, and in the malignant one, it can be invasive growth. Benign tumors always have clear boundaries, which was not happened in the malignant one. And in the benign tumors, it can be completely in the tiling of the cortical bone and no periosteal reactions. And however, the malignant one always have the periosteal reactions. Also, we have a lot of differences in the cell morphology and the biochemical tests and the prognosis. If we know this bone tumor, and we know the second question is this tumor is benign or malignant, so we are going to consider how to solve this problem. As a surgery, we doing the resection surgeries, and there are different ways of resections, and we should know the resection boundaries of the patient. The first we call it the marginal resection. That means in this around the bone tumor. Also, we can use the introsection, and always in some books we say it's a debulking procedure. Means cut part of this bone tumor, and we have wide resection. It's around here. About 5 centimeters around the bone tumor, and we have radical resections, means wide around the radical to resect the tumor. And if that was a malignant tumor, amputation sometimes was considered, but different amputation levels we should know. And intralesion amputation is right here. That means just cut part of the tumor. Also, we are doing debulking procedures, and we can do the marginal amputation. There is just as the margin of this bone tumor, we cut these limbs, and we can do wire amputation. Wire amputation, you cut some normal bones, and the radical amputation is you cross a joint. You can call this radical amputation. We should know the principles of treatment of benign tumors. First, courage with one graft. In the benign tumor, courage was always the first consideration of the surgery. And the ex-genosis bone tumor resection. And this picture shows benign tumor. How do we see? We can doing the courage in this position. We courage and we could do the excision and the grafting. Grafting, we can make a lot of bones graft here, and we have excision here. It was round, and we cut this basal part. This shows the cartilage of this bone. Have bone tumor. We have cartilage and this, and have bone. We grafting this bone grafting. And we have principles of the malignant bone tumors. First, if we are going to treat a malignant bone tumor, life-saving is the first thing you should consider. And they maximize the limb function reserved. In the limb salvage, it's a kind of surgery. And we can do the amputation surgery. And we can do the chemotherapy, the radiotherapy. We can do this radiotherapy, perioperative radiation therapy, or the other treatments. If we are going to have a limb salvage, we should know the key of this surgery. It should be a reasonable surgical boundaries, and this complete tumor resection should be done. While the excision should be cover part of the normal tissue of the tumor capsule reaction zone, and the osteotomy plan. We have 5 centimeters away from the edge of the tumor. We should obey this. And soft tissue resection and the reaction zone was 1 centimeter to 5 centimeters. The indications and the contradictions. The 4 issue that must be considered whenever contemplating limb salvage and in state of amputation. First, will survival be affected by the treatment choice? And the second question, you should know how do the short-term and long-term mobility compare? And the third question you should ask is, how will the function of a salvage limb compare to that of a prosthesis? And the fourth question is, are there any fecal circle consequences? We doing this kind of surgery, we have different methods. First, we have bone reconstruction with autogenesis bone graft, we means autograft. And the second way is doing prosthesis replacement surgeries, like totally hip replacement, or totally knee replacement. And the third way is to join, is a joint reconstruction. We can resect the joint, near the bone joint, near the joint, and make a joint reconstruction. And the fourth way was to muscle reconstruction, and we have revascularization and nerve reconstruction and skin reconstruction. And that means we're doing flap surgeries. This patient have one tumor here in the distal part of the femur. We doing the cartilage of this bone and the bone grafting and using staff instruction nails around here to make these bone stronger and together. This also shows another bone tumor. And this is a bone tumor. You can see elastic things happens. Can we do in limb salvage for this, or we doing amputation? And we cut this tumor. We cut this tumor and use artificial graft here to autograft, and use a nail to make it fixed. And also this is a picture. choose these kind of surgeries. And this is another bone tumor, means sunburst here. And we are doing arthroplasty, and this was a total knee arthroplasty. And it has a pathological fracture, and there is a bone tumor here. We also doing a total hip replacement for this patient. This one was happens in the vertebral. You can see the vertebral is collapsed here. It's a normal vertebral, it's a normal vertebral, and this collapse. We cut the tumor. We cut the tumor and use another instrument around here to stand the force of this spine cord, and we have pedicle screws here to fix this. So let's see the summary of today's bone tumor. First, we should know the clinical manifestations of bone tumors have 4 features. As X-ray finding of benign and malignant on characteristics, and the correct diagnosis depends on clinical X-ray pathology 3 combinations. And the second, we should know the subjects need to focus on metastatic bone tumors. So we should know to understand the concept of neoadjuvant chemotherapy and their significances. The osteosarcoma research focused on the neoadjuvant chemotherapy. We should emphasize the importance of the preoperative chemotherapy, and we should remove the tumor, do necrosis rate checks, and we should decide it according to the level of the tumor necrosis rate. And we should do the post-operative chemotherapy regimens. Thanks. That's all for today.